So next is video 39. It's about sigmoid volvulus and pseudo obstruction. It's actually about sigmoid volvulus. 78-year-old man presents with acute abdominal distension. What are you going to do? So I'm going to take the history. For how long he has distension? Is he painful? Is it vomiting? When last he moved his bowels? Is he passing flatus? And any recent change in bowel habits? Any blood or mucus in the stools? Has he lost any weight? And any other major illnesses? And any previous surgery, any allergies, medications, social history, performance status, and then I will examine him his observations including heart rate, blood pressure, respiratory rate and saturation, the signs of dehydration, and I will abdominal examination. Is he distended, tympanitic, tender? Is he peritonitic? Or an undistal examination, any blood in the stool or empty rectum. And then I will establish intravenous access, resuscitate him, take all the blood including group and save. Then I will recognize, and if his UNEs are fine, we can go towards I will look at the X-ray done by the ED team, and then we might head towards CT scan. So abdominal X-ray shows a coffee bean shaped loop of bowel pointing towards the right upper quadrant. What is the diagnosis? So coffee bean size, if its convex part is toward the right side and concave toward the left side, it's very diagnostic. It's indicating typically presents within the sigmoid volvulus. If diagnosis is doubt, then it can be confirmed using the CT scan with oral IV contrast or the gastrographin contrast enema that will show the Bird's beak deformity with the non-passage of the contrast in the proximal part of the bowel. Now what? The volvulus needs to be decompressed. Now we have to make a decision here. Is the patient peritonitic? Then he needs a laparotomy, if probably Hartmann's. And if patient is not peritonitic, then we can do decompression by a flexible schematoscopy. Why can it not be left untreated with a drip and suck? So because the sigmoid loop is twisted, so it's acting as a closed loop obstruction. So with the passage of time, that will lead to inflamed bowel, compromised circulation, intestinal wall necrosis, sepsis, and death can happen. How will you treat the volvulus? So if there are no features of bowel ischemia or perforation, I would decompress it with a flexible schematoscope and flatus tube. There is 75% success rate and 2.5% complication rate, and this approach can convert an emergency into an elective situation and also allows the assessment of the viability of the colonic mucosa. I will leave the flatus tip in situ for 1 to 3 days and allow continued decompression and prevent the recurrence. The risk of recurrence is up to 90% with the duration alone. That's why within the 2 days of initial decompression, if patients fit, these can generally undergo a safe laparoscopic schematic colectomy with primary anastomosis at an appropriate interval. You resuscitate the patient and place him on the emergency list for definitive treatment next day. What operation will you undertake? So he needs a sigmoid colectomy. Depending on the surgical experts, provided that the volvulus has been reduced and he is otherwise well, a primary anastomosis may be feasible. This can be from an open or the laparoscopic, and that will primary anastomosis avoid the potential morbidity of second operation and to reverse the temporary colostomy. What complication would you discuss with the family? So according to the Montgomery principle, I will tell them the diagnosis and no treatment. What happens if we do no treatment or conservative treatment, and balance with the operative approach, having a GA risks of bleeding, anastomotic leak, ureteric injury, infection, chest infection, reoperation, and stomach wound infection. Calculate the operative mortality and morbidity objectively and document the family discussion in the notes. What if you found infarcted perforated sigmoid colon? In that case, I will do the Hartmann's procedure. And suppose the cecum had perforated due to the obstruction, what would you do? In that case, we will go toward the subtotal colectomy and ileostomy. What would you do if you found obstructed sigmoid cancer instead of expected volvulus? Assuming the rest of the colon was viable, I would proceed to the sigmoid colectomy with an end colostomy. If the proximal colon was damaged, then I would proceed with subtotal colectomy and ileostomy. So in this topic, they didn't mention about pseudo obstruction. Thank you.